So hello, everyone. Thank you for joining us today for our next Science Cafe on the Recover Initiative with Dr. Grace McComsey. I just wanted to start by giving a brief overview of the Clinical and Translational Science Collaborative of Northern Ohio, for those who are not familiar. So it's a collaborative amongst Case Western Reserve University and its affiliated partners that include Cleveland Clinic, Metro Health, University Hospitals, the VA Northeast Ohio Health System, Northeast Ohio Medical University, and the University of Toledo. So the CTSC aspires to be a catalyst for high quality clinical and translational science and transformative research to positively impact the health of those in Northern Ohio and beyond. And this is currently being accomplished through 5 key areas and initiatives that are shown here. So resources and services, workforce development, community engagement, health informatics, and clinical and translational funding opportunities. And so I just wanted to introduce our content expert today. It's Dr. Grace McComsey. She is the Vice Dean for Clinical and Translational Research, the Director of the Clinical and Translational Science Institute, the Principal Investigator for the Clinical and Translational Science Collaborative of Northern Ohio, and a Professor of Pediatrics and Medicine at Case Western Reserve. She's internationally recognized for her research in HIV and has been a clinical and translational scientist at Case Western Reserve for some time. She's authored over 300 peer-reviewed publications in the area of metabolic and cardiovascular complications and the treatment of HIV infection. And she served as a PI on more than 15 NIH grants and has led several multi-center studies through the NIH-funded AIDS Clinical Trials Group. Her proposal to have Cleveland selected to be one of the 14 NIH Recover adult cohort sites has recently been awarded to study long COVID, and that's what she'll be talking about today.
All right. Thank you, Mackenzie, and thank you everyone for joining. What is long COVID? Everybody asks. A lot of people think it doesn't exist. So let's start with that. It's one of those things that tell you how much community and patients are important. The earliest reports of it were patients who went to the media and said, I had COVID, it's been 6 months, I still feel as bad. Things that I never felt before are surfacing. So it was patients and community who noticed that first. And what happened is the media took it. You saw a lot of stuff about long COVID, a lot of social media, support groups. It was clear that there are a lot of people suffering from it. And then it came to the clinician attention. So in the summer 2020, academicians started to talk about it and say, yes, we are seeing a lot of people in the clinic who have either persistent symptoms since they got COVID, or new symptoms that surfaced since COVID. So this is how kind of long COVID was born. And by the way, it's the community and patients that called it long COVID. Usually academician, you hear us refer to it either long COVID or PASC, which I will define in a second. So what kind of presentation? It's basically every symptom possible you can think about. There are more than 200 symptoms that have been described in people who have long COVID. And there are a lot of disabled people in the country. There's an estimate of 1.6 million people in the US who are disabled because of long COVID. So that is not even the mild cases. People are working even though they have some symptoms. These are the worst cases, 1.6 million. So because of that, let me touch on mechanisms. So what are the mechanisms? It is sad to say in a way that 3 years after it was recognized, actually more like 4 years, we're still debating the mechanism. Because it's so many symptoms, it's so elusive. Some people had very mild acute COVID, hardly felt it, and ended up with bad long COVID. It's very tricky new disease. However, there are some studies, including some from our side, that hinted to different mechanisms. mechanisms. The first one is viral persistence. So now there are studies, including one, which I'll show you now, that showed that people who had long COVID, who died, or who had COVID, who died, on average, it was like 5 months after the COVID infection, they found on autopsy a lot of virus in different tissues. So that started actually a lot of other studies where a lot of virus was found sometime in the stools of people who had COVID months and months before, sometime in tissues like gut, CSF, in lymphocytes. So there are a lot of studies that are hinting that there are reservoirs. Now, does that mean that the reservoirs are the causes of the symptoms? We don't know that yet. In other words, if I had COVID, which I had, like all of you probably, and I don't feel anything, do I not have reservoirs in my body? We don't know that piece yet. Another mechanism that I know some of you, I see the names, are interested in working on is dysbiosis. So our group found, and others, that zonulin, for example, a marker of intestinal permeability. So the gut is not working well. There is some leaks that happen. A lot of things go to the circulation, which can activate the immune system. So a lot of gut dysfunction seemed to happen in long COVID. Again, how much of it is responsible for the symptoms, or how much of it is the result of COVID infection? Even if you're not symptomatic, we still don't know that. This is where the controls and knowing which groups you're included in the studies are very important. Another one is autoimmunity, and that's very important. I know my co-PI on the Recover from Metro, Dr. Singer, is very interested in the autoimmunity. And our group, actually using Trinetics, has showed that regardless of long COVID symptoms, after COVID, there was a high incidence of autoimmune diseases. These are people who never had autoimmune, but after COVID, compared to another group that didn't get COVID, in the pandemic era, there was increased incidence of autoimmune disease. So these are the mechanisms that you hear a lot about: gut persistence, autoimmunity, as causing long COVID, although each of them still need a lot more studies. So this study in Cell highlights, in my opinion, the reason I like to cover it is how, because you see 200 symptoms, it's really hard to understand whether each of the mechanisms I talk about is associated with a specific symptoms, for example, or is it just a long COVID as a disease? So this one showed that when they studied with, omics, looking at EBV, CMV reactivation, it was like a pretty, comprehensive study. They looked at people from University of Washington during the acute phase. They had blood on them. They did all these studies and followed people to see if they can pick up some predictive risk factors at the time of acute COVID that will predict who's going to get long COVID. One thing that them and other groups found were type 2 diabetes. So people who are diabetic seem to have higher incidence of long COVID, even if you adjust for everything else. The other thing was EBV viremia. EBV is something that was thought, and that's why in Recover we do EBV actually testing, that maybe COVID is reactivating kind of dormant viruses like EBV that may be causing some of the symptoms of long COVID, like fatigue, right? We know EBV reactivation causes a lot of fatigue. So EBV viremia was one of the predictive symptoms, as well as some autoantibodies. But like I mentioned, what struck me is it's not like EBV viremia was correlated with everything long COVID. It was specific symptoms. Same for GI and respiratory PASC with autoantibodies. So it is really very confusing in a way, the field. There is no one mechanism that likely will explain everything we see in long COVID. So long COVID is going to be pretty much thought of as clusters, different ways of presenting, and each way may have different mechanisms. So I talked about persistence. I'm not gonna be late on that. So some studies that we did here to contribute to the field of long COVID, early on, we did a study that was well publicized that COVID vaccination was predictive of protective against long COVID. So in other words, if you're vaccinated, not only you get milder disease, but it did make a difference in decreasing your risk of having long COVID. So it's a good thing to say that immunization, we're not only protecting against bad acute illness, but also in the general population against long COVID. And we did the same study, but only in HIV, people who are living with HIV, and we found the same thing. So even in people with HIV, if you get immunized, it is still protective against long COVID. Another study that I want to mention is it's not clear yet if you treat people in the acute phase with antivirals like Paxlovid, are you decreasing the risk of long COVID? This VA study showed yes. There was another study that didn't see any signal. So at this point, it's really not clear yet if what you do in the acute phase in terms of medications, whether you take steroids or whether you take antiviral, does it really change the risk of long COVID? It's still unclear at this point, and we need more data on that. So another study that we did to tell you how, you have to think about everything in long COVID. It's such a multidisciplinary disease, and that's why we need everybody's help. We used EndoPAD to measure endothelial function as well as arterial stiffness in a group of people from Cleveland. That's the UH study. That had COVID with absolutely no symptoms. So they're like recovered, you don't think they have anything. People who had COVID with long COVID, as well as people who never had COVID. And what we found actually was fascinating. There was absolutely nothing, whichever way we tried to parse it. Endothelial function was fine, same across the groups. However, arterial stiffness or elasticity was very different. And we did that in two separate cohorts, actually. I'm showing you one of them, but we did it in couple. It's always the same. People who had COVID with symptoms, who have passed, have a lot of arterial stiffness. The difference in numbers in AI is arterial elasticity is very, very significant. 11 versus 3 and 4. So in our study, whether you never had COVID or you had COVID and recovered, you don't have arterial stiffness, but it's really, if you had PASC, that was associated. And there was another paper that's under minor revision now that showed that females seem to get it much worse. And guess what? Female sex is definitely a risk factor for long COVID. Even among our recovered participants, 70% are females. There are a lot more women with long COVID than men, and our study showed maybe why. They seem to have way more stiffness, which could explain some of the symptoms, including new onset hypertension that is common after COVID. So what is Recover? So you probably heard the story of it is in 2021, in February. The NIH had a call. I still remember actually listening to it, where they said, okay, you have 3 weeks to put together projects on long COVID. Now, keep in mind, at that point, we knew nothing about long COVID. So projects, and tell us why your site should be included as one of the hubs in the long COVID consortium. So, so Metro, UH, under the umbrella of CASE, those 3 went into a kind of a local consortium where Metro, led by Nora Singer, and myself at UH, had this grant. And luckily, we were one of 14 adult hubs who ended up getting the funding. And why do I say that? Because it opened up, look at how many different cores, and Recover is huge. People think it's only the observational study, those 40,000 participants. It's not. There is an EHR component, access to 60 million plus records. We have some autopsy studies that are happening. We have clinical trials. Several of them actually are ongoing at UH. And then we have cores who kind of coordinate the study. So NYU is the coordinating center, Harvard, the data statistical center, biorepository is Mayo, and the clinical trial is coordinated by Duke. So a lot of different institutions. I mean, if we didn't submit the grant, actually, it would be sad to see that CASE is nowhere in this huge initiative. So what do? We recruit in the adult cohort. There is a separate peds cohort, but in the adult cohort, we recruit from 14 hubs, 83 sites overall from 33 states. Very diverse population. We do what we call tier 1 testing, which everybody gets, all patients, participants get. And then a subgroup of them get kind of a more sophisticated tier 2 testing, and a subgroup will get even more, some invasive testing as well, to try to figure out more mechanism of long COVID. So this is the tier 1. We get tons of data on demographics. So as I'm actually talking about what we get, what I like each of you, if you're an investigator in your area, right, to think, okay, so if I have all this data and all these samples, what can I do and collaborate with the Recover team on to try to help kind of decipher long COVID? So everybody sees it from their area of expertise, right? And please do. So we have demographics, we have social determinants. A lot of clinical data, I would say, included on the time that they had COVID, what medication they got, and so on. We have physical exam. We have important waist circumference, because metabolic syndrome and metabolic issues are common after COVID. We have those labs and more, actually, but I put some of the labs that we consider tier 1 that are done on everybody. For tier 2, this I just wanted to show you like the extent of the symptoms. The surveys, I feel bad for our participants. Sometimes the surveys are so long, but it is important to really kind of quantify and qualify the symptoms that people are getting. So sometimes it's too comprehensive, but really for good reason. So we ask about everything, actually. We include a lot of different symptoms. So in tier 2, we have oral glucose tolerance test and some testing, as you see here, ACTH, cortisol. We have pulmonary function test, EKG, echocardiogram, rehab exam. I mean, as you look at these tests, obviously they're like all over the place, right? Some are metabolic, some are more aimed at kidney, some are neuro, because again, the manifestations are so wide that you need to study everything. So these are what we call tier 2, a lot of chest CTs, and we've done a lot of those at UH. I know our clinical colleagues have been really good in collaborating with us to be able to do all these tests. And then the probably more important are the tier 3. So the tier 3, some of them are simple, like B12 deficiency have been, commonly seen in long COVID studies. So that's why we're doing that with MMA. But you see, there are a lot of different testing that are invasive: colonoscopy with biopsies, bronchoscopy, right heart catheterization, even invasive CPET, brain MRI, cardiac MRI, gastric emptying. So you see like a lot of different testing done as tier 3. These are going to be really important because we're doing them on a group that has specific symptoms, a group that recovered without symptoms, and uninfected controls. So I think it would be really nice because we have 2 sets of controls in a way. We'll be able to discern the effect of COVID infection itself, regardless of symptoms, and the effect of having symptoms, or what we call PASC, which just occurred to me. PASC is post-acute sequelae of COVID. Why does NIH and academicians like to call it that way? Because some people after COVID may have new onset heart disease, hypertension, diabetes, autoimmune. All of these are well described, even if they don't have any symptoms. So long COVID refer to having symptoms, whereas PASC is not just long COVID, is having any kind of sequelae of the COVID infection, whether it triggered a disease or if it's symptoms or not. So I use PASC usually when I describe what we're doing. So why is it hard to study? Well, of course, if you have hundreds of symptoms affecting literally every organ system, you can't find one that's not affected by long COVID. It's hard to know what are the typical pathognomonic symptoms versus not. They're all over the place. There's no biomarker, and this is where the expertise of some people may help. And you have the right data, you have the right samples. Any biomarker that makes sense, that you want to investigate, that will be a good consortium to work with to investigate. Many people, this is sad actually, I think it's getting a little better, but you have to acknowledge that a lot of physicians, they don't believe it's real. They say, oh, no, it's women, since mostly women, or men who are depressed or anxious, or nah, it's not real. So when you have clinicians who don't believe it's real, it's a problem. And what's happening is now with different variants, with as we go with reinfection, it seems like people who are reinfected, it increases the risk of long COVID. So when people tell me, I don't care about COVID anymore, I'm done with it, let me have COVID, it's mild, I'll do fine. I say, in a way, you're right, except all these mild reinfections that people get, the risk of long COVID is going up. So what you should worry about is not the acute phase of COVID. I worry about the long COVID. And then likely it's multifactorial, and there's no agreed upon definition for what long COVID is. So Recover put out a JAMA paper in 23, and we have another one actually in JAMA that's being submitted, actually I think today or tomorrow, to refine the definition. And basically what we found was these were the symptoms that most defined PASC, and you see the score. So if somebody, what we found is a score of 12 or more is the best score to define PASC. And smell and taste alteration, it's so typical of COVID, even though it can happen in flu way less often. So smell and taste gets a score of 8. So if somebody has only smell and taste disturbance, we can't say 100% that it is really passed. However, if they have it, for example, with chronic cough or with post-exertional malaise, that will get them a diagnosis of PASC. However, it's important to recognize there are other symptoms that may not have made it into the scoring, but they correlate so closely with the symptoms that were in the scoring system. And if you're wondering like how common these symptoms are, these are the past positive participants who got a score of 12 or more. You see post-exertional malaise is very common, as well as fatigue. And that's why you see clinically, a lot of people say, I used to exercise, now any little effort I do, and I'm just totally like out of shape. I have to stop. Fatigue is a big, big one. Although others that you hear a lot about, brain fog, and I know we have physicians who have brain fog, after COVID, it's a big problem. It could ruin actually your career. It could ruin your life pretty much. So you see how common these symptoms are within people who have PASC. So I want to point out that it's clear from recovered data and others that Omicron is not as bad as the initial strain or the Delta strain in terms of risk of long COVID, luckily. So even within recover, people who were enrolled as acute, we have a good subgroup who enrolled during the acute phase, and then we're following them. Only 10% had long COVID or PASC. If you take the older strains, the people who enrolled as post-acute or chronic, recovering, if you had pre-Omicron, 35% had PASC versus those who enrolled and had Omicron, 17%. So that's why these days, when you look at prevalence, and the CDC did that recently, just prevalence across the US, the numbers that you'll see are more in the range of 6 to 10%. So 6 to 10% of the population at any time or now currently seem to have active long COVID, which is not nothing since we are 400 million in the country. So, so we have a paper that I'm senior author on, undergoing very minor revision in Annals of Internal Medicine, where we're hoping it will be accepted and out soon, where we looked at all the tier 1 labs, and pretty much it was sad because none of the big list I showed you was able to differentiate people who are infected versus uninfected, or people who had passed versus not. So the answer for the biomarker is not going to be the regular clinical labs that the long COVID clinic does or that recovered it in tier 1. It's not going to be simple. The other thing is, I mentioned the CDC, 6 to 10%. The last CDC survey showed it to go up by 2 points, 2%. So the point is, with all the reinfection, we're stacking people with long COVID, new long COVID, but the people who have it, the best data, the more optimistic data show that up to 20% will continue, will resolve, actually, up to 20% resolve their symptoms or at least improve significantly. That leaves 80% of people who have long COVID, even after following them for a year or some studies close to 2, 80%, the symptoms are the same or worse. So no wonder why the prevalence is going up. If we keep adding new cases with reinfection and the established cases, very few of them are getting better, the numbers are going up. So Congress actually have their eyes open on long COVID, because they are worried it's going to cost the country a ridiculous amount of money. If you filter in the 1.6 getting disability and people not working, it is a huge a problem for our country. So I'm just going to end it with, so what are we doing to recover? As I said, we have tons of data. We're following people. The idea is following them for up to 4 years. Congress actually want more studies on long COVID. We're in discussion actually to see if we can extend the follow-up, because some things are going to happen long term, not only 2 to 4 years. So we have tons of papers that we're working on in parallel, actually, within Recover, to try to look at our clinical data, our EHR data, our everything that we are doing. We have tons of samples, though. That's what I want to stress, from plasma, from PBMCs, stools, urine, you name it, in addition to the biopsies that's going to collect, bronchoscopy and colonoscopy, so tissue. We really are looking always for collaborators who work with us on mechanistic studies. So please think about it and talk to me about it. I'm more than happy to talk to anybody who's interested in long COVID. And I know some of you know that. It's my favorite topic. So, so collaborate with us on 2 ways: long COVID, but also CTSC. So I know from the names, a lot of you know a lot about CTSC. Remember, CTSC is here to be a structure, catalyzing research. We do want to help with any kind of clinical research, translational research, anything novel that you have ideas. Sometimes you don't know how to get to the CTSC. First, think about us, then become a member. It takes 2 minutes to register as a member on our CTSC, as you see the links there. And if you remember, look out our website and ask for services through Spark. So I would love to collaborate with anybody here on long COVID, but please remember CTSC. We are here to help, and we would love to see mainly young investigators. I mean, we'll talk to senior ones, don't worry, but young investigators who are starting, they want to do something, they don't know where to start. Perfect. CTSC is here to help you. So I think I'm going to stop here. And the idea was not for me to talk for an hour. It's more for me to start, kind of explain about the topic and see if people have any comments. And please keep it informal. I love to hear what people think, or in your area, what do you think you could, contribute or collaborate with us on? So thank you for listening first.
Great. Thank you, Dr. McComsey. So as Dr. McComsey just mentioned, we'll transition now into some discussion. So if possible, it'd be great for people to turn on their cameras just to help with conversation. I do see that there is a question in the chat. It says, are any corporate entities working on therapy for long haul? Any repurposed drugs showing promise?
Yeah, thank you. Corporate entities. Can you clarify what you mean by that? Just to make sure I understand the question. Like you're thinking who?
Yeah, sorry, this is Joe Jankowski. Great presentation, Dr. McComsey. Yeah, just you mentioned you have, the data and samples, and you also mentioned, of course, the fear that this could become just beyond quality of life economically a huge issue in the U.S. and I assume worldwide. Are the pharma or biotechs on this? And, since it would take so long probably to start from scratch, are there any investigations into using, drugs that were created for other purposes that they think may have some utility or efficacy with these patients?
Yeah, great question, actually. So the first one, I think, it took that long without having data on drugs because people, are unsure what to give. When you don't know mechanism, right? It's like, what do you give? But that's why, like, the first two studies within Recover, one was more like a neuro rehab for people who have brain fog, cognitive dysfunction. That one, actually, we enrolled 32 people, second in the nation, and the study closed. So we should, hopefully see the analysis soon. The first study was looking at Paxlovid to give it, longer term to see if that affect in any way viral persistence. So the idea is, okay, if viral persistence happen, how about if we give long-term Paxlovid, does that help? Now, Paxlovid has not been the best drug, as you may know, a lot of drug interactions, side effects. So even though the idea is good for antiviral, it may not make it because of Paxlovid. So we are at UH, actually, we're opening a new study looking at a new drug that I worked on phase 2 on called upamostat, that really made a difference, at least in phase 2. So it was a smaller group, but made a difference in the acute phase. So I'm very engaged with the company, and we're doing now a phase 3 study because we need better drugs. Yeah. So even if viral persistence is a definite mechanism, it's like the drugs we have available are not good enough. So that's why we continue to work on new drugs for antivirals. So the companies, besides Pfizer, for Paxlovid, there's really, like not much. Now we're in a phase where all the companies are saying, okay, so we know inflammation, immune activation seem to be seen in people with long COVID. I mean, we don't know, like, mechanistically, is it because there's a virus? Is it because the gut dysfunction causing it? We don't know. But because there's a lot of immune activation, there are tons of planning now for different biologics, different anti-inflammatory drugs to see if you just kind of attenuate the inflammation. Are you going to see an effect on long COVID? So that's now in the planning, which means, as you know, for clinical trials, when you plan something, give it like 3 years to see results. So as much as we're trying to speed up, there's nothing like really quick in the horizon. And then repurposed drugs, yeah, there are several groups who are looking in their labs using AI to see, is there any drug that seems to have a signal that we should try in humans? So yeah, there's a lot of AI efforts now, including within Recover, the EHR cohort, to see if there are any drugs that seem to give any advantage that we should try in prospective clinical trials.
Thank you.
Sure.
There is another question as well. It says, is the COVID vaccination's partial protection from long COVID any help in identifying or ruling out what possible mechanisms may be?
Yeah, that's a good question. I mean, I would say, we had that study, a couple other large studies were published showing mostly positive result. There are some people that couldn't find a signal, but mostly that vaccination in the general population and in HIV, like I mentioned, we found HIV as well, was protective, but nobody, to my knowledge, is looking beyond that to say, like, why is it protective? Can we learn from vaccination? When patients, described long COVID, there was a big movement from clinicians who were desperate to just, if you have long COVID, say, why don't you take the vaccine? Let's see what happened. And there were some reports of people who were vaccinated after they had long COVID. So you have long COVID symptoms, got vaccinated. Some of them improved, but the larger studies showed no improvement. So basically that when you have long COVID, it's kind of too late for the vaccine to do anything. But yeah, nobody is looking mechanistically to see if we can learn from that. But if any of you have ideas, it would be great. Yeah, so I know if I could comment, I see in the chat, my postdoc Johnny answered one of them. So yeah, the neuro study closed, as I mentioned, but the Paxlovid study is still enrolling. So if you have anybody with long COVID, please, send them if they're interested in learning about the study. If you don't know where to send them to, have them email me. I'm more than happy to get emails from people who are interested in looking at long COVID studies. I think
Grace,
that's all I.
Grace,
Yeah.
a really fantastic talk, and it's really so enlightened. One of the things which made me happy is that there is now community forming around this. It's like what you know very well with HIV. And with the HIV community, it's really what driven that even now we still do a lot of studies in that. So that's a great, really effect. I hope it will continue like we will see what we saw with the HIV. The other thing, I'm also very pleased to know about the microbiome being part of it, because as you know, this is an area which we are very interested. And it's particularly, as we discussed before, we have not only the bacteria, but also the fungi play a role. So it's very exciting area. And I hope with our collaboration, we will do something in that. The thing which is difficult to me, I don't know what do you think, is the complexity. As you say, there are so many symptoms. So to me, I think it will be wise for us to go after certain type of symptoms which we can go after. Otherwise, it will be too confusing.
Right. If you remember when we were discussing the grant that hopefully will be funded. So we need, when we talk symptoms, we need to take people with kind of cardiopulmonary phenotype, neurologic phenotype. So we can't look at every symptom, but we can cluster them into, mostly, and that's how people present, like mostly neurologic, a lot of headache, brain fog, cognitive issues, mostly cardiopulmonary. Or general, a lot of people have GI symptoms. So it will be very important when we look at microbiome, whether in the stools or in the colonoscopy tissues, to have people with GI symptoms, for example, versus people with past without GI, because we don't know why some people have GI or not. So you're right, the choice of participant is so important. And that's why Recover, some people in the news, I mean, you probably read, I keep getting media asking me, why is Recover so slow? Okay, 3 years, we enrolled thousands of patients. We're following them. We're doing all kind of tests. It's a comprehensive disease. And people think like, we're doing nothing. And some, honestly, some of it I understand, like the patients who are suffering from it, of course, you're like, please do something, like fast, because every week to them is a tough week. But HIV wasn't solved in 3 years, as we know. And HIV every year, even now, gets funding way more than the 1.2 billion that Recover got. So that's why we need more funding. And Congress is very willing, because a lot of community, a lot of patients went to the Senate committee and testified about their lives ruined actually by long COVID. So as you know, even among the Senate, actually, kind of feeling people's pain does make a difference sometimes. So they were very touched actually by witnessing, how these people's stories were, and how it ruined their lives. So there'll be a lot of, which is the other reason why we wanted to do the Science Cafe as long COVID. There will be a lot of money for long COVID. The Senate Health Appropriation Committee wanted $1 billion a year for 10 years. They wanted a commitment of $1 billion a year for 10 years, at least. That's what it said, at least for long COVID. So there's a lot of push actually for a lot of money. And this is why, I want the case, UH, CCF, all of our partners in the CTSC to think about ways, can we help you get samples to get some pilot data out so that when those RFAs start coming out and $1 billion is ready, that you'll be ready to submit something. So that's how I want you to think. Like, how can we help you to generate some pilot data to help in grant submission?
There is another question. It says, is the anxiety and depression that you mentioned reaction to having long COVID or a result of the virus?
Yeah, we don't know. I mean, that's why, I mentioned that some clinicians just kind of discard those symptoms and say, it's nothing, it's a woman with kids and she's depressed and she's stressed. And it's all like the stuff that, sometimes physicians, and obviously I'm one, but sometimes when we don't know what's happening, what is the explanation? Stress. So I think a lot of women and some men are getting that from clinicians, like, oh, I don't know what you have, but it's probably depression and anxiety. And the reality is, cohorts that followed people pre and post, these people never had depression in their life ever. Now, obviously, COVID pandemic was tough on everybody, but I have a hard time believing that suddenly just those people without the effect of the virus, with nothing to do with COVID, suddenly everybody became depressed. But the COVID negative group is not depressed, even though they lived in the same pandemic time. So there's a difference, and both groups lived in the same pandemic time, which is the other thing to mention, because I do a lot of metabolic studies, including COVID. And it's interesting that some studies talk about the pandemic era as if it's all COVID. Remember, during the pandemic, right, most people stayed home, ate a lot, drank a lot, everything bad that we did. So there is like a lower health performance because of the pandemic versus the virus. And I think it's so important when we talk about COVID to always include, which is what we do, a group from the pandemic who didn't have COVID. Now, at the start, it was easy to include. Now it's so hard because I think everybody had it. In fact, the studies are suffering. The studies that are trying now to enroll uninfected, they're having a hard time finding really uninfected people. Everybody had it at least once. Now it's not about did you have it or not, it's about how many times you had it. Some people I know had it 6 times. So it's really hard to have good, clean polls now. Luckily, in Recover, we were able to secure 2,500 people who never had COVID by the time they enrolled in the study. And I can tell you the beautiful cohort that we have in Recover is not even those groups, are people who enrolled as uninfected. We have about 500 of them. So they have a baseline, they have blood, they have samples, and became infected on study. I mean, to me, that is a golden cohort that you have a baseline on before infection, and now we're following. That group is going to be extremely precious for Recover, those 500 plus participants.
So that was my question on the anxiety and depression. So I want to follow up a little bit if I could. So in your listing of risk factors, I didn't see anything there that had to do with past trauma or history of depressive disorders or anything in the psych realm. Okay. And then the second question is, are you doing psychological testing? I mean, you mentioned anxiety and depression, but I didn't see names of specific test instruments that you might be using.
We're doing a battery of instruments in the observational study, and anything from PTSD, depression, all of these, PROs we're doing. And that's why I mentioned that our participants, I feel bad for them. They have to fill out so much paperwork and surveys. But the ones who are symptomatic are really excited usually about filling them out because they tell us we're happy somebody's listening to us. Like, you're trying to do something. So we're doing well with people complying with the protocol. So yeah, we're doing that. And then for the neural study, because it's an intervention, we have even, more, not just paperwork, but we need a psychometrician to do them. So like, it's really very tight to make sure that experts are doing those surveys or administering those instruments.
Okay, thank you.
And you're right, yeah, no problem. And you're right about, there are no studies just showing that if you had depression before, you're at higher risk now. I have not seen those studies, but that, that should be, they're depressed. I mean, this is a real thing. It is affecting the brain somehow. So we are doing spinal taps. I mean, we're throwing MRI head, all kind of neuro stuff in Recover to try to figure out what is the effect on the brain.
Okay, good, thank you.
Sure.
There's a comment in the chat that says, I joined the Recover study initially as a control to increase diversity in medical research, but I contracted COVID last summer. Fortunately, my case was relatively mild and I don't have long COVID, but I appreciate your work for my friends who do.
Yeah, and I appreciate you even, being on a study. Honestly, we at UH, we had 1,100 participants. That's from only UH, and then Metro had another 250 or so. So imagine the amount of assistance in a way to long COVID research, to recover research that are cited, which is pretty impressive. We were only second to Mount Sinai in New York. And as you know from the news, New York got so much COVID that for them, they always had a list of people waiting, and we were second to them. But nonetheless, I appreciate everybody who enrolled in the study. And we had some people who enrolled as uninfected, and we are following them, and retention and Recover is 93%. That doesn't happen frequently in studies of 4 years, right? People get sick of coming and they have a life, and 93% remain on the study. So to tell you that people are so engaged and they know this is research that we need to do, that they're helping science. So it's, from that sense, it's really good to see, because it does remind me of the earlier days of HIV for sure.
I wanted to, since we have a minute, regarding the brain fog, I think we can hypothesize if we have imbalance or dysbiosis in the microbiome because of the gut-brain axis, this really have been shown to affect it. So hopefully, we'll be able to tie that down in future studies. But I think it is due to, as you say, the overall symptoms, including the dysbiosis.
Yeah, no, you're right. I mean, the brain CNS, the brain gut relationship probably is at play here. That's why a lot of people have brain fog. So yeah, hopefully we can do that grant and get case to contribute significantly to that part of the mechanism. That would be good.
There's one more question in the chat. Have any stem cell therapies been explored?
Well, yeah, I mean, I know Dr. Singer was interested in cell therapy, and we talked about stem cell initially for acute COVID, but that's now under discussion also for long COVID. So yes, if you look on clinicaltrials.gov, there are sites who are doing it at short, obviously small number of patients, it's not large studies, but kind of proof of concept to see if it works. People are trying everything, trust me, any biologic, anything they can think about that may decrease inflammation or immune activation, they're trying it because people are desperate.
Hi, Grace. This is Jim Dempsey. I work for University Hospitals, I'm not sure if you're familiar with the Corvettes program. It's a, we're starting our third year. I work with Dr. Eli Sadeh, Dr. Robert Salata in the Infectious Disease Clinical Trials Unit. And the Corvettes program, Corvette stands for Cleveland, Ohio Respiratory Virus Vaccines for Normal Risk Factors and Social Determinants of Health. It's a NIH grant that's 5 years long, goes to 2027. And we partner with the CDC, the Cleveland VA, and also CASE, so Dr. Canaday's lab, doing some kind of breakthrough on genomics, studying flu vaccines. We're in the Flu Vaccine Effectiveness Network. And we, during flu season, we recruit patients with acute respiratory illnesses. Obviously, COVID is part of it, and then also the flu A, flu B, RSV. So we're learning a ton just in terms of trends and collecting PBMCs, microbiome samples, and I'm just thinking there could be possibility for collaboration on learnings. We actually just were at a investigators summit at the CDC last week. So our team was down there, Dr. Salata, Dr. Sadeh. And we also have capacity in terms of we are looking for grants specifically around, clinical trials for vaccines. So I'm thinking there could be some synergy here working with you and some of the long COVID. I'm actually a long COVID recovering from back in July of 2020. Wiped me out. I play competitive sports, golf and hockey, and it wiped me out for a solid 6 months. And then the brain fog is a real thing. So it's near and dear to my heart.
Oh yeah, it is a real thing for sure. Yeah. Well, I'm glad you're better, James. You're
Yes.
one of the 20% who improved, so that's good, actually.
Thanks.
Because we see a lot of people, and the more severe the symptoms, they tend to not improve. I mean, it's sad, right? Because it's only the mild ones usually who improve.
Yeah.
It's a tough disease, and it doesn't have exactly the stigma of like HIV that I'm used to, but it does have some stigma. Like a lot of people are like, oh, you have long COVID. Yeah. It's like as if like you're lazy or something's wrong with you. That's why you have long COVID, which is sad. If you're suffering and you get people telling you, oh, that's why you're disabled. You just don't want to work. Yeah, that's not good.
Yeah, and I do wonder about the predisposition for getting respiratory illnesses more frequently then. Does it break down your immune system to allow, the flus and the COVIDs to come back,
Yeah,
easier?
it could be. We need more data on that. I haven't seen anything on it.
Mhm. So,
But the other thing that I know I was asked that I worry about more long-term after COVID is, and something we're going to look at it in Trinetics, we're in the process, is cancer signal. So in HIV, for example, we see the same thing. People who are virologically suppressed, they're doing great, but they have a lot of inflammation in their blood. Whether at the T cells, whether it's monocyte, they have a lot of activation. And in HIV now we're seeing a lot more cancers, and it's unclear why. It's not because of the virus. The virus is not supposed to be oncogenic, but it's really that state of persistent immune activation. So you wonder, if down the road we're going to see a signal for COVID. I mean, without long COVID, it could be that COVID itself can trigger, like cardiovascular and clots and diabetes and autoimmune disease, it can trigger a higher risk of cancers, regardless if you have symptoms or not. So I think this virus, changed the world for good. And honestly, we're only scratching the surface of the sequelae or effect of this virus long term.
yeah, agreed. Definitely. Thank you.
All right, no problem.
Yeah, I see
All
we are
right,
at
we're
time.
Yeah.
So thank you so much, Dr. McComsey. There are some links in the chat to become a member of the CTSC, provide feedback today on how the session went, and also a place if you have any suggestions for a future Science Cafe, you can put that there. And then there's the registration for next month's Science Cafe on Parkinson's disease. And I'll also send a follow-up email with these links. So thank you everyone for joining today.
Thank you.
All right. Thank you, everyone.